You will be surprised, but actually the patients that I had on the community hospital were not that much different from the patients that were in the trauma center, in the sense that you still had the same, when a patient is dying, they're dying regardless. Like, you still have to start all of the vasopressors, you still have to do all of these therapies, and it's still on like a time race where you have to be quick. You cannot take 30 minutes to do one order. Oftentimes you have even your coworkers helping you with a patient that is actively trying to go. Like, sometimes there will be 3 nurses trying to get all of those orders done. But the trauma center, so they're similar in that sense. It's ICU, so people are very sick. They're at the highest level of sickness acuity that they can be for that hospital. So that is the same. And the foundation I have saw that is the same. Like, an ICU is an ICU. I would hope everywhere, but at least it has been in my experience that community hospital or not, you still learn the basics of what being an intensive care unit nurse is. Now, when I have worked in a level 2 trauma center, and the patients that I got there had more complications, were more complex, in the sense that we weren't just dealing with like your basic infection and the blood pressure is dropping. You were dealing with gunshots, with stabbings, with motor crashes. I didn't get to experience the open heart surgeries because, like I said, I've only been a nurse for 2 years. So in all of this, when I got to the trauma center, all of the invasive procedures with the heart were stopped because of COVID. So I didn't get experience with impellants and stuff like that, but the patients overall were more like in less pieces, I guess you could say, oftentimes. So it was more pressure. So although the basis was the same, because it was the same, honestly, but just working in the having 2 patients in the level 2 trauma center was more difficult than having 2 patients at the community hospital, because at the community hospital you would never have a gunshot. You just never do, because the patients don't get shipped to that hospital to begin with. But in the trauma center, you will have a gunshot where you're transfusing 20 units of blood and you have your other patient. So it was a lot harder in that sense, a lot more stressful. What made me wanted to become a travel nurse? To be completely honest, I got burned from working in the trauma center, but I have to say why. Right in the middle of the pandemic, our governor, our wonderful governor, flexed the ratios. So ICU nurses were getting 3 patients, 3 to 1. So now I wasn't only in a community hospital, I was at a level 2 trauma center. So even having 2 patients was hard. And now you're giving me a 3rd patient. So that was just, I got burned out in the few months. I worked there less than half a year. And that was actually the main reason why I started traveling, because I saw that I was getting 3 patients, and oftentimes 3 of the sickest patients that were possible on the unit, because I was new in the unit. So the older nurses would most likely get preference. Like, they would get the patients, not easy patients, but they would get the most stable patients. They wouldn't get new admissions because those are very unstable. They wouldn't get upgrades from like telemetry or med-surg because those are the crashing patients. So usually administrators will give the heaviest assignments to new grads, however unfair that sounds, to travel nurses, or to just new hire nurses. because they don't have to please those kind of staff because they're new. They haven't done their due. They haven't done their time there. So I was very burned from having 3 patients at a level 2 trauma center, for the pay that I was getting. I felt like I was just getting beat down, and for pretty much nothing. So then I started traveling, and now I also got beat down during my assignment, because in this assignment, this particular hospital was even breaking the new staffing ratios. They were giving their nurses 4-to-1 in their intensive care unit. And then they fixed it to 3-to-1, but at least now I was being compensated for the amount of stress that I was getting. So in this, just advocating for myself in general, has got me in trouble throughout my career. Even when I was a new graduate nurse, in this said particular hospital, I did spoke up a couple of times about how little training they were giving us, and because you're a new graduate nurse, what you say doesn't really matter. You're just another hole on the wall. So that didn't go anywhere. And then when I went to the trauma hospital, they were going through a lot of changes. So there wasn't much to be done, just because of the pandemic. Like, you're in the middle of the pandemic, so everybody knows that the conditions are unsafe, but nobody can do anything about it. And then advocating as a travel nurse is a lot more tricky and a lot more dangerous, in my opinion, because as a staff nurse, you're able to speak up, and administrators, even if they don't like you, they're not gonna fire you most of the time just because you spoke up. But as a travel nurse, it is very common and very easy to have your assignment canceled because you spoke up. So thankfully that didn't happen to me, but I have had coworkers who have said that they try speaking out, and then initially management appears to, oh, thank you for your opinion and for raising this concern, and then the next day their shifts just get canceled, and then a week later their whole contract gets canceled. And now you have nurses that are, for example, here in California, that are from Idaho, and now they have to go back from one week to another, and they don't have another assignment lined up. So speaking up against unfair or unsafe, not even unsafe working conditions, oftentimes, if not most of the times, comes at the expense of the nurse. She will be the one who will lose her job. She will be the one who you either suck it up or you go home. So as an example, in said facility, the facility is good. It's a wonderful facility. I actually like the nurses there, but when I got there in this last travel assignment that I did, they were giving us 4 patients, 4-to-1 in the ICU. And of course, same behavior happened. They were giving their staff nurses the stable patients. Now, when it's 2-to-1, if you're quick, you can do it. Like, you can have 2 unstable patients, and if you're quick, you can catch up, or at least ask somebody for help. Now, when you have 3, now it's a balancing act. But there were times that they were giving 4 to nurses that didn't speak up for themselves. That didn't happen to me. They try, the charge nurse one time tried to give me 4 unstable patients, and I just said no, because I can't. Because I know myself. I know that the most I can handle is 2 dying patients, actively dying. I cannot handle 3 or 4. So, but that was a recurring. I saw that was a thing in this facility, and this change of facilities, because this hospital that I'm talking about is not just one hospital. They actually have several hospitals, and it's one of the most coveted hospitals in California. Like, it's one of the highest paying hospitals. And anytime I tell this to any coworker that I ask, they all get surprised, because who would think that this hospital would do this to their nurses, but hey. So it got to the point that they were trying to give us 4 ICU patients. I spoke up and I brought to the management's attention and to the staff nurses' attention that the governor flexed our ratios to 3-1, not to free for all or like 15-1. You know, like we still had ratios even though we were in the middle of the pandemic. We were 3-1, not whatever the hospital wanted us to have. But many nurses in general were not aware of that. They just thought that we could get as many as we could, or as many as the hospital wanted us to, which wasn't the case.